Well, welcome. As you mostly will know, my name is Juan Olazagasti. I'm a pediatric gastroenterologist with Carilion Children's Hospital. And here we are on the Launch or Learn, talking about eosinophilic esophagitis. And I'm going to have some few disclosures. One of them because we were involved as a division in a pharma research with Regeneron, one of the makers of dupilumab, the maker of dupilumab, a medication approved actually for eosinophilic esophagitis. And also, we're involved now with another study regarding EOE as eosinophilic esophagitis with Celgene, and that's a new study targeting interleukin 13 that we're about to start anytime soon. The other disclosure is that the slides that you're going to be seeing today were courtesy from Dr. John Mark Stone, which is our new person, the new doctor or physician in our division. So I appreciate Dr. Stone letting me use this nice pictures and nice slides from his property. So thank you, Dr. Stone. The objectives, we're going to be looking at definition of eosinophilic esophagitis, epidemiology, pathophysiology, the diagnosis, how to make the diagnosis, and then how to treat EOE. And I'm going to talk about eosinophilic esophagitis as EOE. So our definition is this is a chronic, local, immune-mediated esophageal disease, mostly related to symptoms of esophageal dysfunction, dysphagia, and specific pathology findings of eosinophil predominant inflammation, aside from ruling out any other systemic or local causes of eosinophilic or eosinophilia in the esophagus.
Doctor, I'm sorry to interrupt. We're not seeing any slides.
Can you see?
Yep, now we're there. We're good.
All right. Well, that's great. Sorry for that. Right. So we are all right. So sorry for whoever has joined. This is Dr. Olazagasti talking about eosinophilic esophagitis, and I did some disclosures about these two particular pharma medications that have been approved. Well, the first one, Regeneron, dupilumab, and then the second one is another medication that we're involved as a division of GI regarding the treatment of EOE, and that's about to start at any moment. Then we're talking about the objectives, definition, epidemiology, pathophysiology, diagnosis, and management of eosinophilic esophagitis. And I did mention about a disclosure. You all heard that that these slides were according to Dr. John Mark Stone. So thank you, Dr. Stone. Definition. So this is a chronic local immune-mediated esophageal disease. And this is characterized by symptoms of dysphagia, difficulty swallowing, and biopsies which showed inflammation because of eosinophils after you have ruled out any systemic causes of esophageal eosinophilia, which we're going to be talking a little bit more about that in a little bit. So the diagnosis is mostly by endoscopy and biopsies. So greater than 15 eosinophils per high power field will give us the right diagnosis for EOE. In addition to that, there's other specific inflammatory type of process, but mostly the amount of eosinophils per high power field. And if there's anybody else that are not necessarily familiar with how the pathologists do that, they get an average of how many eosinophils in different high power fields that on the tissue itself, and then gets to what is this average. And it's very sensitive and specific compared to gastroesophageal reflux disease. So just as a note, in GERD inflammation, we usually see less than 15 eosinophils per high power field. And technically, you're not supposed to see any eosinophils in the esophagus. So any eosinophils that we see is significant for the purpose of the biopsies. Other causes of esophageal eosinophilia in the differential diagnosis: infection, Crohn's disease, achalasia, hypereosinophilic syndrome, hypersensitivity, drug hypersensitivity, and graft versus host disease. Those are typical causes of eosinophilia. But I have to tell you that we see quite a bit of Crohn's, and it's not common to see eosinophilia in the esophagus as far as Crohn's or achalasia. At least that's what I'm more familiar with. Right? The symptoms, well, you see mostly feeding problems in the first 5 years of age. And then towards the 5 to 10 years of age, aside from probably seeing some degree of feeding difficulties, you may see vomiting as a more predominant symptoms. And then you have that area between 10 and 14 years of age that abdominal pain could be the most predominant type of symptoms. And then as you move into late adolescence and adulthood and adult, then dysphagia and food impaction are the most prevalent type of symptoms. We do see children, younger children with dysphagia, don't take me wrong. It's just that in the early life, in the early years, you see more of feeding problems, vomiting, and abdominal pain, which it's amazing that, you know, you really have to look into endoscopy in these particular scenarios if they're not better with what you suspect originally, because EOE could be a factor. So when looking at pathophysiology, genetics has brought a lot of information and a lot of treatment alternatives. For example, the TSLP gene that you see here that was characterized in 2010, and this 5q22 is the loci, and this actually it codes for this particular protein TSLP. That is a thymic stromal lymphopoietin protein, and that induces T helper 2 cell development and activates eosinophil and basophil. So for example, when we're talking, and let me give you a background of what type of inflammatory immune process eosinophilic esophagitis is. It's mostly through a T helper 2 type of process. And this is more what you see not only with food allergies, but also with asthma, atopy, and allergic rhinitis and sinusitis. So all this group of disorders and diseases are related to a T helper 2 type of immune activity. The T helper type 1 is most infectious type of process. And then you have the IgE mediated type 1 allergic reactions, which are mostly the anaphylactic type or the delayed hypersensitivity reaction that we see, for example, in allergic colitis in infants. But this is in particular characterized by the T helper 2. And the other important gene is the CAPN14. And this one, it actually codes for an esophageal proteolytic enzyme that also involves damage to the lining of the esophagus. And it's actually mediated by this cytokine, this protein released by the eosinophils and the T2 helper cells, which is the interleukin 13. And the finding of IL-13 in terms of what is the meaning of how to block this interleukin and help EOE has been very important in the development of some of these biologics that help in reducing the eosinophils and treating EOE. Other important ones is that CCL26 that induced by interleukin 3 and encodes for eotaxin 3. Eotaxin 3 is another big problem as a cause of inflammation in eosinophilic esophagitis, because it's not only it brings more eosinophils to the area as a chemoattractant, but it's an activating factor for damage and mucosal disruption and inflammation. Then you have the STAT-C down here, which actually it's a downstream signaling for interleukin 4R alpha, interleukin-4 receptor alpha, a very important receptor in terms of inflammatory process in the actual eosinophilic disease. Then you have different factors affecting or involved with eosinophilic esophagitis. And you look at, for example, gender. So eosinophilic esophagitis is more common in males than females. And we'll see that in the next slide. Same with environmental factors, for example, how important is factors of whether disruption of our microbiome with a cesarean section versus a vaginal delivery, or the use of antibiotics, or the use of formula in the feedings versus breastfeeding. These particular factors can affect the presence of some bacteria, and which I'm going to talk to for that in a little bit, that also increases the inflammatory or the T helper 2 type of immune process. There's some factors with cold weather or climates that they're not as significant, but they're there. And then the H. pylori brings the question of, well, H. pylori stimulates the T helper 1 immune mechanism. And there was a question at some point whether H. pylori, the decrease of H. pylori incidence in the last probably 10, 15 years, has that bring more towards the T helper 2 type of disorders like the EOE type of, because there has been, of course, an increase in eosinophilic esophagitis, and there has been a decrease on H. pylori, but that particular scenario has not been, that particular question has not been answered. And of course, there was a question, is H. pylori protective against eosinophilic esophagitis, or but it's not clear, but there is a factor. Whether it's good or not is not sure yet. So atopy is a big one in terms of seasonal variation. The increased rate of food allergies through IgE, which also is to some degree linked to patients with OE, even though those for IgE mediated allergy, it's not necessarily the food that triggers eosinophilic esophagitis, and we'll talk about that in a little bit as well. The cellular pathology, how activated eosinophils damage the esophagus, the mast cells, and how all this inflammatory process affects the mucosa, the barrier in the esophagus that causes more inflammation. Inheritability. So it's seen mostly in Caucasians, and there's an increased relative risk in families as well. And then there's some genetic variants, and these are all related to, for example, this gene SPINK5, DSG1, that they're all disrupted and causing that could cause potential similar disorders of eosinophilia in the esophagus through these genes as well that are actually seen through eosinophilic esophagitis. We're going to mention a little bit more of that in another slide. So the pathophysiology, let's talk about risk factors. I mentioned about cesarean section, and what happens is it affects the host commensal disruption. Then it creates some increase in bacteria that could be affecting this particular Th2 profile. I mentioned about male more predominance, Caucasian, and antibiotics in early life. Even antibiotic in adulthood can also trigger or in EOE. Why? Because the use of antibiotic can increase the potential of proteobacteria, granulicatella, and Campylobacter genera. But aside from these ones that has been able to be cultured, there is a good 300 other bacteria that has been identified, not by culture, but they could not identify them by culture, but by PCR, which could relate to the development of inflammation and eosinophilic esophagitis. So disrupting our flora our microbiome is a big deal in the development of some of these conditions. And not only this mechanism, mostly also other inflammatory conditions like inflammatory bowel disease, and other autoimmune conditions. Then we'll talk about cold and arid climates, which the incidence is not, great. The odds ratio is 1.39 or 1.27 respectively. Lower population density, and then the connective tissue disorders that I mentioned that have some linked genetically to eosinophilic esophagitis. For example, Ehlers-Danlos syndrome, joint hypermobility syndrome, and Marfan's disease. And here we go and talked about the pathophysiology, how this process of inflammation goes through and what are the triggers. So you have here in the left upper about foods like milk, egg, wheat, and microbes that interacting with the esophageal epithelium stimulates the release of cytokines that are more pro-atopic type of cytokines like interleukin 33. And then you see that again, the stromal lymphopoietic protein, the thymus stromal lymphopoietic protein that also then triggers this particular T cells, these T regulatory cells and T helper 2 cells, as well as some of the eosinophil and mast cells to produce cytokines, inflammatory cytokines. They call it pro-2 cytokines because they then becomes and start a chain of inflammation and triggering another genes that would then be released by eos and mast cells and basophil as well, affecting proteins like periostin that are linked to fibrosis and collagen deposition, and then remodeling, which causes then strictures or rings in the esophagus, affecting swallowing. And this particular protein in here, the transforming growth factor beta, is a big one also in down-regulating positive effects of the causing more, for example, fibrin deposition, and then strictures and remodeling of the esophagus. And you have these other inflammatory markers. There's the CAPN14, which triggers more eosinophilia, more inflammation, more disruptions of the barrier. It downregulated this particular desmosine type of. This is a desmosome type of gene. Is protective, but this particular gene also, the CAPN14, decrease this particular beneficial gene, and then causes more damage or triggers the potential for more damage. Eotaxin 3, another big inflammatory cytokines. So at the end, the release of these granules containing different proteins, for example, eosinophil-derived neurotoxin, eosinophil cationic protein, eosinophil peroxidase, all damage and causes inflammation in the esophagus. Then you have dilated intracellular spaces, decreased junctional proteins, all affecting the base, the barrier of the esophagus, causing inflammation. So very interesting. And all these genes have been mostly developed in the last 10 years. The amount of information, looking back to research from 2010 or less, or it's amazing how much we've learned about this interleukin affecting inflammation. For example, interleukin 5, we were thought to be one of the main causes of problems with eosinophilic esophagitis, but blocking interleukin 5 in research has not stopped the process, the actual progress of the disease. So we were involved in one study way back that involved the IEL5, and we all thought that that was a big interleukin to block. But the ones that is approved, the Regeneron, the dupilumab blocks the 13 and block these two are the ones that have shown so far a big deal of help in decreasing or helping eosinophilic esophagitis. We'll go to the next slide. So know this, that, for example, people with gastroesophageal reflux disease can interfere with barrier balance and health, and then can potentiate the disruption, or can help the development of eosinophilic esophagitis, even though eosinophilic esophagitis and gastroesophageal reflux disease is a total different disease. But having GERD disease can affect or can potentiate the development of EOE as well. Aeroallergens and IgE are not, they can be seen in more frequency in patients with eosinophilic esophagitis, but some of the food allergens that are tested through immunoglobulin E, the RAS test, they may be positive in the RAS test, but those not necessarily are the actual cause of eosinophilic esophagitis. So in the population, you may see an increase of environmental factors affecting, or there's more tendency to have IgE related food allergies, but not necessarily those particular food allergens are the one triggering eosinophilic esophagitis. And we know that because the use of omalizumab blocking IgE is an anti-IgE antibody has not helped eosinophilic esophagitis. So that's important to remember. What is very important is this immunoglobulin subclass 4, which plays an important role in EOE, and it's been elevated in food-specific IgE in tissue and plasma. So how we diagnose, again, endoscopies, number one, is a chain that is an invasive study. It requires sedation or anesthesia, but at the same time is the way to see whether there is swelling, edema, decreased vascularity. This specific findings that we're going to see in some pictures in the next slide, causing longitudinal furrows, which are edema, rings, trachealization of the esophagus, white plaques, which are actually microabscesses, crepe paper esophagus or strictures. And there is a reference score for gross features that we're going to go into the next slide. So overall, you have to do an endoscopy to diagnose EOE, because you may you need to biopsy the esophagus when you're suspecting EOE. Even though it looks grossly normal, you need to biopsy, because a good 10 to 32% of cases may look normal and they still have underlying pathologic abnormalities. So we usually take at least from the distal and proximal esophagus. Most of the time, that's good enough, but there's a lot of gastroenterologists that will take not only from the distal and proximal, but also from the mid esophagus, and 2 samples from each side is ideal. Here we go. So this is actually the reference gross score for endoscopy. So you have the edema, rings, exudate, furrows, and stricture. And when we're talking about edema, you know that there is edema because there is loss of these tiny capillaries that you see in most healthy, normal esophagus in children and adolescents. Then you see there's a blunt surface. Then here for trachealization, these are rings. You start seeing some very subtle things on this grade 1, then you more pronounced on grade 2, and then severely pronounced in grade 3. Then you look at the white plaques. These are microabscesses caused by eosinophils. There you go, grade 1 and then grade 2. Most of that we see is grade 1 in here. And it looks like candida. It looks like yeast. And sometimes we have to brush it to be sure that it's not yeast. But once you see this, once you see this longitudinal furrows, and then with the symptoms of the patient, you're pretty sure that it's not yeast, but it's always good to brush and send for stain on culture for HIFAS if you're concerned about concomitant presence of candida. Then furrows, these are these lines that you see all along here that could cause because of swelling and edema, and then the definitive strictures. We don't see as much strictures in pediatrics, but in adults, strictures are quite common, and dilation is part of the treatment for eosinophilic esophagitis. We're going to go to the next slides. This is the histologic picture of EOE. So again, greater than 15 EOs per high power field, you see a lot of degranulated. So all these pink and purple cells are eosinophils, and then you see all these tiny degranulation granules where they have those sort of peroxidases and all these inflammatory chemicals that increase inflammation. Then you see dilated spaces because of edema. You see papillary elongations of the papilla. If just to remind your histology, these are these tongue-like findings on the lamina propria that in inflammation it goes very high into the surface of the esophagus, and you see them coming in really high in here in eosinophilic esophagitis. Then you see surface aggregates of eosinophils. You see that, and of course dense and fibrotic tissue in the inflammatory process. I'm just going to go to this particular slide. Is not as important. We do mention that there are some grading type of findings depending on severity. For example, from 0 to 3, depending on the amount of cells, eosinophil, you have grade 1, which is less than 15, which is actually negative, grade 2, which is between 15 and 59, and greater than 59. But mostly, once you see more than 15 and you have the specific inflammatory process, that's the diagnosis. The symptoms are very important too. Fibrostenotic finding, whether you have trachealization, and this end of flip is an endoscopic elasticity study that right now in pediatric is more for research, but it helps to find out or to determine how much stricture or how much tension there is in that esophagus going into what we call remodeling. Again, strictures could be quite obvious, and the symptoms of food impaction, which is quite often as well. I have to say that allergy testing is not very helpful to diagnose which food causes eosinophilic esophagitis. So in the RAS test, the IgE microarrays, is only helpful in 7% when there is histologic remission. Same with the skin prick or atopy patching testing. The positive positive predictive value is only 47 and 44% for each of this, and so they're not completely helpful. We do send our patients to allergy testing anyways, because if they're negative in many ways, the negative predictive value is quite high, except on the case that they have a milk protein allergy that is only 30% helpful and 31% in the atopy patching testing. So most likely, in a way, we add up in what specific allergy testing we can do to actually tell parents, hey, if you avoid this particular food, your child is going to be very likely to be almost 100% well. We do know by experience that eliminating milk, for example, milk protein, will help in 33 or so % of patients, and the same with other particular foods that I'm going to mention in the near future here in another slide. But mostly we're really tied up with what specific testing in terms of food allergies are helpful. So the European eosinophilic esophagitis guidelines would tell us that the utility statement, they have a statement saying that the utility of the allergy test in the identification of food triggers of EOE is consistently low in adults and it's very variable in children, which is absolutely true. So we are really limping in that particular area. So we know that the duration of untreated disease is a major risk factor for eosinophilic stricture, rings, and complications. So the evidence suggests that adequate treatment can reverse esophageal remodeling in a lot of cases, mostly in children and adolescents. In adults, once they have the strictures, once they have that, it's really impossible to reverse all those fibrotic changes. But in children, there's a lot to help in these particular patients. So when we're talking about treatment, we're talking about the use of proton pump inhibitors, the use of topical budesonide or Flonase. These are steroids, and the use of food elimination diet. And then now we have a new biologic available that it just approved 6 months ago, dupilumab, in the treatment of eosinophilic esophagitis. So let's start with proton pump inhibitors. So mostly there is a percentage, 50% of patients with eosinophilic esophagitis that will respond to high dose proton pumps. For example, either high dose omeprazole, lansoprazole, any of them, will help in 50% of the cases. And there is even more help if you divide the dose by 20 milligrams BID or 50 milligrams BID, depending on which of them you're using. It doesn't matter which PPI you use. Okay, they're all good. And we do know that if you use a PPI, a good 70-80% of them will maintain remission up to a year, even if you try to load the dose in half, or 0.5 milligram per kilogram per dose, or per day, I should say, once you document after 2 months that there is resolution and help with the PPI, then you can then slow down on the actual dose and observe whether the patient continues to do well. And you have to repeat another endoscopy, of course, at some point in 3-4 months. But all this is really helpful to in at least half of the population with eosinophilic esophagitis. You have to be mindful about long-term side effects of PPIs as well. You know, they can affect calcium absorption in the GI tract and can be responsible for osteopenia or osteoporosis. And all these side effects you have to keep in mind. So you have to keep good vitamin D levels, or supplement vitamin D if needed, or supplement with calcium, all that. But PPIs, there's a group of patients with eosinophilic esophagitis that will respond to PPI. And let me tell you, they are not related to GERD itself. This is actually a separate group. It's a subgroup from eosinophilic esophagitis. This is the research data supporting PPI use in children and adolescents. Then the next group is topical steroids, and these are effective in reducing a good 64 to 99% of patients. And we're talking about mostly budesonide. Budesonide, you use the same ampule of the aerosolized, the use for asthma, and then you use some usually Splenda or any type of sugar-free sweetener, and they add 1 pack to that particular 1 cc or 2 cc, so depending on the dose you use, and they take that twice a day. And the other help is Flonase, but because Flonase is more an inhalant, there is less effectiveness, only 13 to 62% of efficacy. There are some pharmacies, some compound pharmacies that will give you they will make a viscous solution to help with the budesonide. But most of the time, what we tell parents is just to add a Splenda or something like that. That's sucralose. The long-term use of budesonide is safe. What you try to do is same with the PPI. After 2 to 4 months of using it, you try to reduce the amount in half, and there is good remission rates of 73% at 3 months and 36% at 50 weeks. The side effects, esophageal candidiasis, you can see that around 10% of patients with the use of budesonide, but you treat it. The only thing you have to treat it for 6 weeks with fluconazole. But I'll tell you, topical steroids are quite effective, and there is at least less absorption of these particular steroids compared to prednisone and other systemic steroids. This is data research behind the use of topical steroids in EOE. And then diet, which in my opinion is number one treatment. And for example, elemental diet is effective in a good 91% of with patients with histologic remission. The problem is, how to ask a patient to either drink or take an elemental formula, which is amino acid formula, for long periods of time is impossible. We have had patients with severe EOE and severe feeding disorders where we have depended on using a G-tube for feedings because they won't eat mostly anything by mouth. And then we have used elemental diet in the form of amino acid formula, which effectiveness, very effective treatment. But this is limited to these particular patients that do not eat much because they have developed such a severe feeding aversion through the years that we can use an elemental diet. But in most situations, we depend on, avoidance of, for example, the six food elimination diet, which includes dairy, protein, egg, peanuts, tree nuts, seafood, soy, and wheat, and that's 72% effective. And then the other option is a 4 food elimination diet, which includes the dairy, egg, soy, and wheat, with a good 54 to 71%. And then the 2 food elimination diet, which is basically eliminating dairy, protein, and gluten, with a good 40%. And as I said before, if you eliminate only dairy, milk, protein, it is around 30% effective. The problem, of course, adverse effects, poor palatability, decreased quality of life, poor compliance, very difficult for families, as we all know, to actually have one child with all this avoidance, and then they have another 2 children that can eat anything. So it becomes a big challenge for families. So in my experience doing gastroenterology, I'll tell you, I've had very few patients that are willing to even do the milk protein avoidance, and so it's really difficult for families and expensive at the same time to do any type of elimination diet. And what happens is that let's say that you start with 6 food elimination diet. So after 2 to 3 months, you have to repeat another endoscopy and document whether the child is better. Then you have to choose which particular, if there is improvement, then which particular food you're going to remove. Most of the time, you avoid dairy, would be the last one, because dairy is one of the major proteins causing EOE. So then you have to repeat endoscopy, because there's no other way that we can actually monitor the progress unless we do endoscopy. Research is trying to find ways to detect through blood testing these particular changes, whether they're reliable in terms of how better the patient is. But so far, we don't have any definitive help for that in particular. So we depend on endoscopy. This is research behind diet elimination diet. And again, another management tool is endoscopy, because you can dilate in cases of severe dysphagia with rings or stricture, and it's quite reliable and safe. A 75% improvement. The question is, for how long? Because it can be 2 weeks versus from 2 to 6 months. Actually, most patients will get better for a few months, but then again it goes back. But endoscopic management is a big deal or big help in adults when they have already chronic scar tissue and they have strictures and rings. The perforation and hemorrhage risk is low, as you can see. So when we're dealing with a patient with eosinophilic esophagitis, the question is, what are we going to do? So the first option to offer the parents and the patient is, can we do a trial of a proton pump inhibitor for 8 weeks? And that's at least you know that half of the patient will respond or may respond to a high dose PPI. But if the family are more willing to do elimination diet, or they think that they prefer just budesonide because they're afraid that the PPIs can be long-term a problem, then we have to talk to the family, give them the options of what to do, and go from there. Now we have the biologic dupilumab, but then I have to tell you, I will leave dupilumab for situations where we have failed PPI and we have failed budesonide, or because not only is very difficult to get that approved, but at the same time, it's a great tool to have it available. A lot of the patients do quite well, and you can actually manage to treatment for 3 months, hold on treatment, see how they do, and then sometimes the parents tell you, doctor, oh, don't do an endoscopy. Can we just treat him again? Because he's doing so well, he's not vomiting any longer, and he's not choking, or he's not. And I sometimes let it be, and then treat them again for another 2-3 months, and they do fine. But in terms of the menu of what to do, if you treat with PPIs and they respond, and they have very few eosinophils, like 0 to 4, then you can use, for example, then you can let it be and just reduce the dose, and you can treat them for a while. If they do not respond, then you have to decide on the rest: topical steroids, dietary therapy, and go from there. And in the sense that they're so severe that they don't respond to topical steroids or dietary changes, then you have the other either systemic steroids, esophageal dilation, these other type of situations where it's more left for severe patients with EOE, which I'm just glad that we have another biologic. This kind of reminds me when we have patients with severe Crohn's disease and severe ulcerative colitis, that we have the availability to having a biologic treatment, and we didn't depend on steroids to keep them on steroid long term. So the development of biologics, which is going to expand, I bet, in the next 5-10 years, is phenomenal to the treatment of EOE. Here, this is investigational treatments that from all of this is dupilumab, the one that was approved 6 months ago. So this is no longer an investigational tool, but I checked on all these other ones, and they're still pending. They're still on research without any definitive final. And again, to this, I will add Celgene, the ones that we're involved. We're going to start another research on the next, hopefully next month or so. And then we have this particular vonoprazan, and this is a different type of PPI kind of. It's a potassium competitive acid blocker, and this particular, it's even stronger than the PPIs, and it's more for this particular patient that responds to PPI. That's a hope for the future. So in conclusion, eosinophilic esophagitis is a chronic inflammatory disease through a T helper 2 immune response. Appropriate treatment is important to reverse complication of stricture, rings. The social aspects of these particular children and adolescents are amazing. They get so scared to eat. They get embarrassed if they're afraid to eat in a restaurant because they may get choked, and all that is a big deal. So having treatments for these particular cases and identify them is crucial. There's no associated risk of cancer with these particular patients with EOE. All studies have shown that there is no gene-related or any particular symptoms or signs in histology associated with any particular cancer type of gene. And new advances in therapy will continue to provide effective treatment, as we've seen already. Of these patients that do not respond to PPI or diet elimination or even topical steroids. And I'm happy and glad to be able to share this information with you. There are some advocacy groups linked to eosinophilic esophagitis. I wanted to leave that on file, and I'm open to any particular questions or comments. Thank you.
Hi, sir. This is Austin Drake. Question for you, and I may have missed it. So if we have a patient with concern for EOE, do you want them started on a PPI empirically as they come to see you, or would you prefer them come to you first before PPI is initiated?
Thank you for the question, Austin. We will prefer to have them referred and then having the evaluation. There is suggestions, as you saw in that particular algorithm, that the patient could be potentially start 2 months on the PPI and then do the scope. And in a way, the reason they do that is to you help one step. You know, if the patient responds to PPI, then you say, okay, then we'll keep it on PPI. But the problem is that not everybody with dysphagia will have eosinophilic esophagitis. So there's some patients that will have dysphagia, but it's mostly because of globus sensation or globus hystericus, and not necessarily EOE. So yes, I would prefer for them to be not started on PPI in our situation. So have to have evaluation, get a baseline endoscopy, and go from there. Yeah, that would be my preference.
Perfect. Thank you.
Thank you. Very good. If there's no other questions, I will go. Well, I appreciate your time and attention here. Thank you.